All right, this is Kayla Skeet, and this will be part 2 of our pediatric neuromuscular and musculoskeletal disorders lecture. This slide starts by talking about common lab and diagnostic tests. First, you will see x-rays used frequently. These are used to detect fractures, and these x-rays are typically taken from 2 views to give a very good picture of the bone. We also see myelography is used to assess neural tube defects. This is an x-ray of the spinal cord that can be used to view nerves and meninges. We might see this used in a myelomeningeal case where we're trying to get a really good view of those nerves and meninges in the sac that's protruding from the spinal column so we can assess the level of intensity of the defect. We also see CT and MRI used frequently. These tests may be used to assess for a wide variety of abnormalities, including neural tube defects, fractures, especially fractures of the skull, SCFE, which is slipped capital femoral epiphysis, and to rule out other problems such as a mass or brain tumor. EMG or nerve conduction studies may be used to differentiate between disorders of a muscular origin or a neurologic origin, and we also see genetic testing used commonly. This slide outlines common medications that you should be familiar with for the neuromuscular and musculoskeletal systems. For our exam, it is important to be aware of some of the nursing implications when administering these medications to your patients. So in the case of benzodiazepines, such as lorazepam or diazepam, we saw these used in the neuro lecture for seizure disorders and for status epilepticus. We may also see them used for skeletal muscle spasms. It is important to monitor for sedation, specifically for respiratory depression when giving benzodiazepines. Baclofen may be used for skeletal muscle spasms and spasticity. This is especially common in CP or spinal cord injury. It is important to note that the dosage of baclofen must be tapered before discontinuing the medication because the patient may experience withdrawal symptoms, which may include seizure activity. Botulinum toxin is also used for the relief of spasticity in CP, and we will talk about that a little bit later in the lecture as well as we jump into CP, but important to know that that is a medication we may see administered. Acetaminophen and ibuprofen NSAIDs are used for pain relief. These may be used in combination with narcotics for further pain relief, or acetaminophen and ibuprofen may be used on their own if the patient is having mild to moderate pain. It is important to reassess your patient's pain level about 1 hour after administering, especially when we're giving these oral pain medications. We want to give it time to work. Narcotic analgesics may be used for moderate to severe pain relief, such as in the case of a severe fracture. It is important to monitor for respiratory depression and sedation when giving narcotics, and again to reassess pain about 1 hour after administering when we give these medications orally. It is also important to note that narcotic analgesics may cause nausea, vomiting, and constipation for your patients. Next, we'll move on to a discussion of congenital structural anomalies. First, we will discuss pectus excavatum and carinatum. Pectus excavatum is a funnel-shaped chest. You can see it in the image on the right of your screen where you see a depression typically at the xiphoid process. This condition is more common than pectus carinatum. Pectus excavatum may result in cardiac or respiratory compromise. As you can imagine, the more severe the depression in the chest is, the more issues with compression and compromise of the cardiac and respiratory system. This condition may require surgical correction before puberty, and typically it is corrected by a steel bar being placed or sometimes a bone to lift that depression. Postoperatively, the child cannot roll in bed, lie on either side, flex or rotate the spine in order to prevent the bar from being dislodged. The steel bar will typically be removed about 2 to 4 years after placement when the defect has been corrected. Pectus carinatum is a pigeon chest or a protrusion of the chest wall. This one is less common, and you see that the chest wall protrudes outward. This is mostly a cosmetic issue for patients. They're self-conscious about the way that it looks, but it doesn't cause the same issues of cardiac and respiratory compression. You may see that this condition can be effectively treated through the use of a brace or a compression brace worn over the protrusion on the chest. Limb deficiencies are another congenital structural anomaly you may see. These deficiencies develop in utero. They may be due to maternal exposure to harmful substances in utero, or they might be due to an amniotic band that is wrapped around the limb that constricts the limb and then results in this limb deficiency. The focus for these children is on promoting their functional ability, getting them connected with PT and OT to work on achieving normal developmental milestones or appropriate developmental milestones for their condition, and then working on activities of daily living as well. Syndactyly is the webbing of fingers and toes. This may require surgical correction, but it's mostly done for cosmetic purposes because parents or the child themselves don't like the appearance of the webbing. Polydactyly is extra fingers and toes. Surgical correction is often done to remove the extra digit. You can see an example in the bottom right corner of your screen of polydactyly. Occasionally, the extra digits, especially on the feet, will impair their gait or their ability to walk. They may need special shoes or orthotic devices until surgical correction is done to remove the digit. Congenital club foot is another structural anomaly. This is seen as an inverted heel with forefoot adduction, and you can see that in the image here where the forefoot is turned inward toward the body and it cannot be moved passively past the midline. So this is where we differentiate congenital club foot from that metatarsus adductus we talked about earlier in the lecture. That metatarsus adductus is just that normal inward turning of the forefoot of infants due to their positioning in utero, but we can grab onto that forefoot and we can move it passively to the midline and past midline. But in this case of congenital club foot, we cannot passively move that foot past midline. Congenital club foot may be bilateral, so we might see it in both feet, and males are affected more often than females. There are four main categories of congenital club foot. Postural may resolve easily through serial casting. Neurogenic clubfoot may be associated with conditions such as myelomeningocele. Syndromic clubfoot is associated with other syndromes, and this is the most resistant form to treatment. And idiopathic occurs in healthy newborns. Treatment for congenital clubfoot is often focused on the goal of promoting function for the patient. Treatment is started very soon after birth to improve outcomes. Serial casting is often the first step, and this is done to slowly straighten the foot over time. The child may need corrective shoes and braces during early childhood and beyond, and in some cases, surgical release of the soft tissues may be needed if casting is ineffective. Next, we will discuss several genetic and developmental disorders. The first disorder we will discuss is osteogenesis imperfecta. This is a genetic bone disorder where we see a high rate of fractures. The patient has a low bone mass, fragile bones, and other connective tissue issues. Other complications we see related to osteogenesis imperfecta include hearing loss, acute and chronic pain, scoliosis, and associated respiratory problems. The most common type of osteogenesis imperfecta is an autosomal dominant inheritance pattern, so they get the affected gene from one parent, and it causes a defect in type 1 collagen. This is the most common form of osteogenesis imperfecta, but you will see there are several types of osteogenesis imperfecta, some more mild and some very, very severe and not compatible with life, where we see the babies pass away typically in utero or hours after birth. So you can take a peek in your text if you're interested in several of the different types of osteogenesis imperfecta. We will focus on this most common type, as that is the one that we will likely see in the clinical setting. Therapeutic management for OI has a goal of reducing fractures and maintaining mobility for the patient. Medications that may be given include bisphosphonate administration. This medication is given to help increase bone mineral density and to hopefully reduce the incidence of fracture. The patient will also need PT and OT and often the use of supportive braces. When caring for the patient with OI, you may see lab testing done such as a skin biopsy. This will show abnormalities in the type 1 collagen, which can be diagnostic of osteogenesis imperfecta, and we commonly see genetic testing as well. For your nursing assessment, when you're gathering your health history, it would be important to ask about a family history of a high rate of fractures. There's a chance that someone with a very mild case of OI doesn't know that they have it and they just had several fractures as a child and it went undiagnosed. Or there may be a family history of osteogenesis imperfecta, so it's important to ask those questions. On the past medical history, it's important to ask for the child if they have had frequent fractures in the past. And on physical exam, you may note a bluish sclera, so the white of their eye actually appears blue or gray. We may note possible abnormalities of their primary teeth, and this is associated with certain types of osteogenesis imperfecta. And we may also see joint hypermobility. For nursing management, we are promoting mobility for the patient. We want them to get up and to move around because we know this helps to increase their bone and their muscle mass, but they may need adaptive devices, such as the kiddo in the image on the left of your screen has an adaptive walker to help him ambulate. We also educate families about avoiding trauma, so trying to prevent fractures. It's important to talk to them to handle their child with care, much more care than for another child. If the parents have older children, it will be different than what they've done in the past. It's important not to push or pull on the child's extremities. If they're holding their hand and helping them walk up the stairs, it's important not to push or pull. Do not lift the baby's legs up to change the diaper, which is really commonly done. Better to have mom and dad roll baby over onto their side so they can wipe baby's buttocks instead of lifting up their legs. And do not lift up the child from under the armpits. You can talk to parents about gently lifting their child by supporting their back and supporting under their legs, but really taking extra care to prevent any of those fractures. The next genetic condition we will discuss is muscular dystrophy. This is an inherited condition that leads to progressive muscle weakness and wasting, and progressive is a very important part to remember. Duchenne muscular dystrophy is the most common form, but there are several other types. We will focus on Duchenne muscular dystrophy for our class, but you can review the other types in your textbook if you're interested. This type of muscular dystrophy leads to an absence of the protein dystrophin in the muscles, and it results in weakness, specifically of the voluntary skeletal muscles. That progresses then too. We first start seeing that weakness in areas such as the hips, in the thighs, and the pelvis, as well as the shoulders, and this will then progress to weakness of the cardiac and the respiratory muscles as well. This condition is inherited in an X-linked recessive pattern, so moms are typically unaffected carriers, and the affected son gets an abnormal X from mom and a Y from dad, and then they develop the condition. Signs and symptoms. We often see that these children are late walkers, so not walking until after 15 months or walking at 18 months. We may see pseudo-hypertrophy of their calves, so the calf muscles themselves appear very enlarged. The child may have frequent falls. They may be especially clumsy. They may struggle to climb stairs and to run. A very good question to ask is your child able to keep up with their peers? And the answer will often be no. Another cardinal sign of muscular dystrophy is Gowers' sign, and you can see that depicted in the illustration on the right of your screen. So when the child is rising from the floor, they can't just stand up normally. They don't have the strength in their voluntary muscles to stand up as a child normally would. Instead, they slowly rise from the floor by getting on their hands and knees, pushing themselves up, and kind of having to walk up their body into a standing position. These children often have normal intelligence with some learning disability. Children with muscular dystrophy are often wheelchair-bound around 7 to 12 years of age as their condition continues to progress. Muscular dystrophy is normally diagnosed in childhood around 3 to 6 years of age, so the child might have very normal movement, relatively normal achievement of their developmental milestones as an infant and toddler, and then they reach preschool age and we realize they can't keep up with their peers and they're starting to show some signs of weakness. Life expectancy for individuals with muscular dystrophy is typically the 30s, but they may survive as long as age 40 to 50 with advances in medical technology such as mechanical ventilation that can be used in the home setting as well. Therapeutic management for muscular dystrophy may include the use of medications such as corticosteroids to help slow the progression of the muscle weakness. It's important for you to be aware of some side effects of corticosteroids in the pediatric population. These include weight gain, long-term use can lead to osteoporosis, and we also see mood changes. ACE inhibitors or beta blockers may be used to help reduce the workload of the heart, which is especially important later in the muscular dystrophy progression when we start seeing a lot of cardiac issues due to that weakness of the heart. Calcium supplements and vitamin D are given to help prevent osteoporosis that may be related to the corticosteroid use. And antidepressants may be needed for mood changes, either related to the condition because the patient has a chronic illness with a terminal diagnosis, or because of the use of corticosteroids altering the mood. It is important, as the nurse providing care to the patient, to promote mobility and comfort. The patient may require braces, mobility aids such as walkers and wheelchairs, and orthotic devices. Contractures can be common, and these may require surgical release. The development of scoliosis or kyphosis may occur later in the condition, and these may require spinal fixation, and the patient will need physical therapy and stretching exercises. Diagnostic testing that may be performed includes an EMG to differentiate the cause as muscular and not neurologic in origin. Labs such as creatinine kinase may be drawn, and the creatinine kinase will be elevated early when there is significant muscle wasting occurring. Muscle biopsy is the definitive diagnosis. When we do that muscle biopsy, we can see that there is an absence of dystrophin, and genetic testing will commonly occur as well. This will conclude part 2 of our lecture series. We'll pick up part 3 talking about cerebral palsy.